Dr. Gazzard, thanks so much for doing this. Could you start by telling us a bit about the normal mechanism of aqueous fluid production in the eye and how it's normally drained?
Okay. Aqueous humor is produced by the ciliary process of the ciliary body and then percolates from the ciliary body through the pupil, over the surface of the lens, through the pupil and then into the anterior chamber. So very roughly, with some terrible drawing, if you've got the iris here, you've got a ciliary body sitting just tucked in underneath there. Here's your cornea at the front and there's the outside world. Pupils here, and you've got a lens sitting just behind there with zonules to the ciliary body, which is the other function of the ciliary body. So you produce aqueous by active secretion. It percolates over the surface of the lens, through the pupil there, into the anterior chamber and bathes the surface of the anterior chamber. It will then drain, this is obviously in cross section, into the angle here, and the trabecular meshwork is sitting just in this recess. If you're looking from the front and you've got the pupil there, you've got a 360-degree ring of tissue into which the aqueous fluid's coming through the pupil and then draining out of the eye.
Brilliant, thank you. So in acute glaucoma, what sort of goes wrong with this process?
Acute glaucoma is more accurately acute angle closure glaucoma, or acute angle closure, because what happens in this process is that in susceptible individuals, the lens is sighted slightly more anteriorly relative to the pupil plane, and that means that there's a relative blockage of fluid flow between the iris and the lens, and because there's a relative blockage there, you build up a pressure differential across the iris structure, and that pressure differential, analogous to a sail, causes a pressure to push the iris forwards, so you get iris bombé, and that's when you get an iris that sits forwards like that in front of the position that it would normally occupy, and there's a pocket of aqueous humor sitting behind there, pushing it forwards like a sail. That means that this iris then gets pushed up into this angle. This angle here narrows, and what you eventually end up with is this iris in contact with the trabecular meshwork, obstructing the access of the aqueous in the anterior chamber into that drainage angle. So you get angle closure there. In acute angle closure, you end up with a vicious circle or a vicious cycle where the iris swells slightly, the pressure differential continues to push that forwards, but aqueous continues to be made, and obviously the pressure inside the eye rises very rapidly. Sometimes those episodes are broken spontaneously. Patients come in and they've had headaches for months or years, they've had episodes of very high raised pressure for years, but every time it happens, it settles down or it resolves. In acute angle closure, that doesn't resolve, and it ends up in a situation where it can't resolve itself and you need to treat it.
Okay. So you mentioned headache. How else would these patients present? How would you spot acute angle?
Ocular, periocular pain, generalized headache. A lot of these patients, sometimes once they've had preventative treatment to stop this happening again, come in and say, my migraines have disappeared. In fact, they've been having some sort of pressure-related pain for sometimes years. You often get a sore, red, painful eye. Once the eye pressure becomes very high, the eye itself will become red, the conjunctiva becomes injected, the conjunctival vessels dilate, so you end up with a red eye. The vision will often become blurry because the cornea, at very high pressure, the cornea will become edematous. So the corneal endothelial pump fails to adequately pump the fluid out of the cornea to keep its clarity when there's a very high hydrostatic pressure gradient, and then therefore the cornea becomes swollen and then becomes cloudy and you can't see clearly. Characteristically, that also presents with symptoms of, or traditionally described as halos around bright light sources in dim rooms. So people see a variety of different descriptions, but little rainbow star patterns around lights. Sometimes they've got a full halo around a bright light. That's caused by scattering of the light, where the corneal collagen fibers and fibrils are spaced inappropriately by the increasing swelling within corneal edema. But you also have quite profound systemic symptoms. So some people feel very nauseous, feel very sick. Some people end up vomiting because they have a sort of effectively a sort of vagal stimulation. There are plenty of instances of people being admitted to general surgical wards with repeat vomiting, even mammary vice tears, hematemesis as a result of their vomiting, and then they go through a whole assessment for that, when in fact it was a precipitating cause, was actually their acute angle closure.
Fine, okay. So a doctor in A&E or a doctor on surgical take, what would be the signs that they need to try and pick up on examination?
A sore red painful eye, particularly with a reduction in vision. If they've got eye signs, eye symptoms, if one eye is much more clearly red than the other, and if they describe an acute recent sudden reduction in visual acuity.
Okay, and it's always unilateral?
No, it's rarely it's bilateral. We had a case series in a case control study that I did of acute angle closure in Singapore of 115 cases, of which slightly over 10% were bilateral. But bilateral cases are more common in East Asians. Right, okay, fine. Sorry, you've got me on my MD subject.
Yeah, pet subject. And so what are the main risks of acute glaucoma? What are the sort of end points that we're worried about?
The risk factors for developing the disease are female gender, increasing age, and particularly Far East Asian descent. Those are the individuals who are particularly prone to the disease, but it does happen and can happen in anyone. The consequences of untreated acute angle closure are ischemic damage to the vulnerable structures within the eye, and the most vulnerable structure is the iris. So you get ischemic iris damage, get a fixed dilated pupil as a result, but ultimately you can get pressure-related nerve damage. So you can end up with, within a matter of a day or two, start developing permanent, irreversible pressure-related optic neuropathy. So irreversible glaucomatous optic neuropathy.
Fine. And finally, how do we manage these patients? What do we do in acute glaucoma?
The first thing to do is to try and reduce the intraocular pressure. You can do that with aqueous suppressants. Cetazolamide or Diamox is a very effective aqueous suppressant, where they're given. Normally these patients can't take it orally because in severe cases they're vomiting. So we give it intravenously, and that acts more quickly, but often with then some follow-up of oral Diamox as well, so there's a sort of slow release component. Very high intraocular pressures, pupil constricting pilocarpine doesn't work because the iris is ischemic, so it can't constrict. But once the pressure comes down, the pilocarpine that you give to treat it will begin to act and begin to bring the pupil down. And a constricting, reduced pupil size tends to reduce the tendency for this obstruction to fluid flow, causing that pressure differential that I was talking about, that was causing that iris bombay. So you've got the lens here. This tends to happen when the pupil is mid-dilated. If we constrict the pupil so the pupil plane flattens out, then this tends to allow the fluid flow back again. So the mainstays are aqueous humor production suppression with Diamox, topical timolol, beta blockers if they're able to take that, sometimes other intraocular pressure lowering topical drugs. Pilocarpine to constrict the pupil to try to break the actual pupil block element. And then the definitive treatment is to make a hole in the iris, which is the iridotomy, with a laser from outside. That equalizes the pressure the pressure gradient across the iris and allows fluid flow through that hole, so that you've bypassed the pupil block, which is the sort of the underlying cause. Also, definitive treatment is lens extraction and cataract extraction. Lens extraction in the hot, inflamed eye carries its own risk to the corneal endothelium. It's more difficult surgery. So is generally left until some weeks or months later. We did do a randomized control trial I did a randomized control trial of early lens extraction, which showed better results, but there were significant risks. Right,
okay. Thank you so much. So we like to finish it just by saying, say I was an F2 doctor in A&E or a GP trainee, or indeed a final year med student, what would you say are the 4 take-home points about acute glaucoma that we mustn't forget?
Always consider it as a differential diagnosis of intermittent severe headache, particularly periocular or uniocular eye pain. To take a history that asks about visual symptoms in association with blurring of vision, with intermittent blurring of vision in association with headache and redness of the eye, particularly episodic, classically occurring in conditions of low light levels.
Okay.
Look for people who've got long-sighted, hypermetropic glasses is a characteristic point. And I've only come up with 3. I have to think about the 4th.
That's good. 3 is 1 less to remember. Thank you very much. Thank you, Mr. Gazzard.
Welcome.